yearly calendar for all the catering to the first year, second years, and final years. With these few words, I welcome all the faculty. And today's faculty is our Professor and HOD of Orthopaedics, GMC Ananthpur. And welcome, Raghunandan. Very, very happy to have you here as a faculty.
Thank you, sir.
And then Shivananda will assist me. And I am there as a moderator. And my junior colleague, Santosh, will be there. And shortly, other senior faculty are likely to join, like Ravindranadh sir will join. And Patil sir will also join. And then our topic today is, first topic is hip, diagnosis of the hip made easy. It was a wonderful talk which we had in the WhatsAppCon 22 at Ongole, but I thought this is the right platform for all the postgraduates. It's a very wonderful, a easy way. In fact, I don't call it a shortcut. It is a made very easy. Hip diagnosis is always has been enigma. Even today, I find it difficult to make some certain diagnosis in hip conditions, even right now the last 40 years. So the hip is a wonderful joint to examine, to diagnose, to investigate. Even hip radiology is also very fascinating. And you think it is infection, sometimes it will be turned out to something else. So in all, hip is a wonderful topic to discuss n number of times. And also in the examination also, every examiner will like to discuss hip joint. Okay, and along with that, we added, if the time permits, one short case of infection. That also should be interesting for all the postgrad, because a short case which is commonly kept in the examination. With a few introductory remarks from me, now I request Raghunandan to go ahead with his talk on the diagnosis of the hip. Thank you, Raghunandan. Now,
thank you, sir. Thank you so much for your kind words. I really thank NAOA for allowing me to give this talk, which was, with pardon, I should say that it is prepared for OSAPCon 2022 because of, I could not even change for NAOA. Please pardon me for that. But still, the content is the same, so I just wanted to go with the same slides as well. I thank Udaykumar sir and Shivananda sir for their graceful attitude to allow me to do this presentation to the postgraduates. I welcome all the postgraduates to this session. This session is, it's not new to you. You must have heard it a number of times from your all senior teachers. There's nothing new in this, but this kind of a organized way of bringing your attention to as to how to make a clinical diagnosis in the hip. See, hip joint is always kept for you in the examination. Sometimes they may not keep you the spine, but hip is going to be there. That you must all understand. So you have to make a diagnosis, though you know that the diagnosis is, already told to you by your seniors or the people outside. It's not possible for you to correlate your findings with your diagnosis at the examination hall. So this presentation is meant for that purpose, especially to make you aware of what you are telling to the examiner, to make you aware of how close you can come to your diagnosis by your findings, and to make you, assess, at least if somebody has not told you the diagnosis, you should be able to at least guess your best guess. So that is the aim of this presentation. So sorry for the slide. Right now I am at Ananthpur Medical College, that is Government Medical College, Ananthpur. So this, a few days back, I was in Kurnool, so the slide went with that. Okay. So right now, okay, why clinical diagnosis? So we have got a lot of MRIs and CTs and nice, beautiful digital X-rays. So why clinical diagnosis? You must be having something in mind. So don't believe shadows. So you see only shadows in the X-rays. They are basically two-dimensional. You take CTs, they are three-dimensional, but you get varied details. Even if you look at a normal CT, you believe there is a problem, unless somebody tells it's normal. So don't believe shadows. Believe in your own capability of doing the clinical examination, come to a diagnosis, reasonable diagnosis. To correlate disease better, you have something in mind, but the investigation will show something this different. Then you, just to make sure that
recording in progress
correct, it is better you have a clinical acumen. And to plan management. So when we see a radiograph, you do not plan your management according to the radiograph. For example, simple example, you take X-ray of the knee, patient may have severe osteoarthritis, but is not symptomatic. You don't treat an asymptomatic patient. That is the basis of it. You see an ACL tear in the MRI, patient is not having instability, don't even touch him. You learn a lesson if you touch him. So to plan management better, clinically, you must have an idea of what's happening inside. And then finally, regarding your plan of management, and of course, yourself, you should make sure that your clinical diagnosis is correlating with the radiological diagnosis or investigative diagnosis, whatsoever it is. And of course, to start empirical treatment. So sometimes in India, it's possible, but abroad, to go for an MRI, it takes 3 to 4 weeks. So you suspect something, you wait for MRI till then the disease will progress. So in order to start empirical treatment, you must have some clinical acumen in the mind, which holds good for the hip also. And of course, it's expensive, may not be in India, but outside it's very, very expensive, and availability is scarce. And then waiting period is long for most of the investigations that we go along with the hip joint. Of course, when you are making a clinical diagnosis, you should not be too rigid that you are only the correct person in making the clinical diagnosis. You must always take the help of investigations, but clinically you must have some idea. Then only you can correlate it with your investigative plethora of investigations like X-rays and then biological or biomarkers, everything. Then we go to other slide. How to proceed? How to proceed? A step-by-step examination is very, very important. You cannot take history and go on to palpation. Step-by-step examination is extremely important. That's why they have it divided all these things: history of present illness, past illness, treatment history, all these things. A step-by-step examination is very important, which will narrow your perspective of making a diagnosis. So initially you have 10 things in mind. By the time you go to your palpation, only 2 should remain. By the time you finish your measurements, you should come to one diagnosis. That's how a step-by-step examination. It's called a learning curve, learning ladder. Every step refines your diagnosis. That you must understand. You're not simply looking at the patient and then making some nonsense clinical findings. Every step of you touching a patient, seeing a patient, will refine your diagnosis. You have 10 diagnoses, that becomes 1 at the end of your clinical examination. So diagnosis you can make by history, diagnosis you can make by inspection, diagnosis you can make by examination. So in examination, you do not have auscultation and percussion in our department. We have movements and measurements. And we do have certain things, what is called as special tests also in orthopedics, which will really get your diagnosis straight away without looking even at the X-ray. We see how it goes. So let us see, depending upon the age, what are the common diagnoses that are possible. A child comes to you, what you will have in mind? The diagnosis of Teplic arthritis, Tom Smith's, DDH, Perthes disease, upper femoral fascial slip, and then tuberculous arthritis. These are the common diagnoses that you get when you look at a child who is come to you with an orthopedic problem. Okay, if an adult comes, what diagnosis you will have in mind? Common, we are talking about only common diagnosis here because in the exam point of view, we're discussing TB hip, AVN, non-specific arthritis, which is by exclusion, primary arthritis, which is little rare in India, and then secondary arthritis. So these are depending upon the age group, you have these diagnoses in your mind when the child or an adult comes to you. Let us see the laterality. If it is confined to one side or 2 types, that is unilateral or bilateral. So if it is confined to one hip, that is unilateral, if you think it includes possible trauma, tuberculosis hip, and sometimes, I wouldn't say always, sometimes AVN, SUFI, and Perthes. So these are the common unilateral hip affections that a patient will come to you with a pain in the hip. Okay, then the enigma comes when the patient comes with a bilateral hip pain. Then in the bilateral hip pain, which is commonly kept for you an examination patient, usually in DNBs. So where you see, you have to rule out other systemic diseases also like rheumatoid arthritis. Think of endocrinal problems like calcium metabolic diseases. Think of drugs producing hip problems like steroids. Think of anti-inflammatory inflammatory arthritis like ankylosing spondylitis and other seronegative polyarthropathies. Of course, AVN, SUFI, and OA are definitely bilateral conditions also. So you have a case of bilateral hip disease, you have also these things in mind. Then let us see, depending upon the onset, what diagnosis we can make. Usually you have onset like acute onset, subacute, and then chronic. So acute onset generally we take in terms within 3 weeks. Subacute, we don't consider much. It's only a differential diagnosis. Chronic, you say, let's say 6 months, 3 months to 6 months. Ideal period is 6 months. So when a person comes to you with a hip pain or a hip disease, which is of acute onset, you think of what conditions? Usually an infection first. That is what is called as septic arthritis, which is very, very common in children below 12 years of age group. In an adult, if a patient comes to you with an acute hip, you think in terms of inflammation, the most common cause is rheumatoid arthritis. In case of children, we have differential diagnosis like, non-specific arthritis of the hip joint or non-specific synovitis or irritable hip. All these things will come when it's an acute duration. So the feature of this acute duration is, acute hip is, it's usually progressive. The child will come with pain now, the pain will increase tomorrow. So it is usually progressive. It's not going to be static. They may have other systemic symptoms as well, like fever. And usually in case of acute infections, they do not have any fixed deformities. They may have restriction of movements, but they do not have any fixed deformities. So these points are extremely important for you to make an acute hip. In case of chronic hip, you have all your exam cases like trauma sequelae, you have ICNF, ECNF, central dislocation, AVNs. You have infection sequelae like tuberculosis, sepsis. You have inflammation sequelae like rheumatoid arthritis hip and then non-specific arthritis, and then osteoarthritis. And then altered mechanics sequelae, that's usually the secondary arthritis like SUFI, Perthes, and old trauma. So depending upon the onset, when the person says it is acute onset, you have a few things in mind. When a person says it is chronic onset, you have all these things what you know in your mind. Then we go to complaints with which they come to you first. The first and foremost and important, and you cannot neglect the most important complaint is pain. Without pain, they will never come to you. They will never come to you for limp. They will never come to you for instability. They will never come to you for limb length shortening, which is very much acceptable in India. So the first thing they come to you is with pain. Usually the pain is associated with limp and other constitutional symptoms. So without limp and other constitutional symptoms, the pain will not be there. If you have pain, you have antalgic gait, you have limp, you have other constitutional symptoms. So it's a sign of inflammation that you must remember. So in case of acute inflammatory diseases or septic disorders, you will have definite pain. So pain is the first and foremost symptom that the patient will come to you. Usually in chronic conditions, pain will lead to stiffness. Pain will lead to stiffness, that is restriction of movement. Then the deformities and limb length discrepancies and gait abnormalities will come, which are a feature of chronic diseases of the hip joint. So first and foremost symptom that you have to inquire is what is called as pain, then associated with limp and constitutional use in case of acute. In case of chronic, is associated with deformity and limb length discrepancy and gait abnormality. That you must know. So the pain, when you ask about the pain, they have two types of pain usually, severe and moderate. Severe and moderate. So let's see which conditions will have acute, that is severe pain. In case of acute conditions, it is septic arthritis, obviously. You have severe pain. The child will resent your examination. That is a sign of septic arthritis. No need to touch the child. You ask him to do something, he will resent. You will ask him, he will just throw you out. That is the diagnosis of septic arthritis, how you make. In case of certain other things like rheumatoid arthritis, ankylosing spondylitis, and seronegative arthritis, you have severe pain, but they are usually flare-ups. They subside. Without even treatment also, they subside. So there are flare-ups. There are acute conditions which are associated with other symptomatology like systemic, like fever and all that. In case if the pain is moderate, in case of moderate pain, there are two types. They may have fever, they may not have fever. So pain moderate, no fever, it is a diagnostic of non-infective, non-inflammatory conditions like AVN or OA, osteoarthritis. When the pain which is moderate, if it is associated with fever, then first diagnosis should be tuberculosis. And usually and very rarely there can be a non-specific arthritis as well. So no fever, moderate pain, first diagnosis is AVN followed by OA. With fever, the first diagnosis should be tuberculosis, at least in India. Okay, let us see some of the telltale symptoms in history. We have talked about the pain. We talk about other things. So we go to history. If the patient tells how to make a diagnosis. Okay, let's say acute pain, fever, and then functio lisa. That means absence of movement of a particular joint is called as functio lisa. That means no function at the joint at all. So this is diagnostic of septic arthritis. I told you earlier, the child will resent your examination. You try to move the limb, he will kick you out of his bed. It will be so severely painful. It's an extremely painful condition is septic arthritis. So don't forget, septic arthritis is so painful. Single degree of movement will produce severe pain, that you must remember. The next thing, history, which will point out to the diagnosis, what is called as night cries, and then constitutional symptoms. I hope everyone will know the diagnosis, what is called as tuberculosis. Very simple to make a diagnosis. You just extract this history. So you should be careful enough to extract this history. If that child will give a correct history of this, make a diagnosis of this, you cannot be wrong many a time. If the person gives you history of remissions and exacerbations, what is your diagnosis? It is rheumatoid arthritis, or in gents, usually it is ankylosing spondylitis, which is common only in males, rheumatoid arthritis in females. So easy to make a diagnosis. Remissions and exacerbations in females is rheumatoid arthritis. Remissions and exacerbations in males is ankylosing spondylitis. That's it. So a painless limp in a child, you know the diagnosis, what it is? This is otherwise called as Perthes disease. Very easy to make a diagnosis. And then a painless limb in an obese child who looks endocrinologically a little bit abnormal. You know the diagnosis. I need not tell you, it is SUFI. See how easy to make a diagnosis by just asking a few important points in the history. So you cannot simply go on asking what is your profession, what do you do. All these things are important to complete the case sheet, but to extract a diagnosis, a few important things that you must have in mind when a person comes to you, and ask specifically whether they are there or not. Of course, if nothing is there, nobody can help you. That's a different aspect. Later on, we come to that. But if something is found, a clue, then you can straight away make a diagnosis. That's why I'm telling all these things. So next comes diagnosis of history by history of trauma. So the child says or a person says there is a history of trauma. If there is a significant trauma around the hip joint, then you expect major fractures like pelvis, acetabulum, trochanter. Pelvis fracture, usually it will not interfere with our examination, but acetabulum fracture is very important for us. And of course, trochanteric fractures. Very, very rarely, there are associated fractures like fracture neck of femur, shaft with the neck of femur, those things, and fracture head of femur. Of course, they are major. They are major, and they are a little bit away from our point of discussion today. They are possible, but don't think of unusual things first. Think of common things first, which are for which the purpose is the case is kept for you in examination. Think of those things first, and then go for unusual things. The kids have a habit of telling first unusual things to show their subject or whatever it is. It is good for you. Maybe it's good for you later. For the examination, it's not going to really work. So usual things, common things first. Maybe wrong, doesn't matter. Speak of common things first, then you go for unusual things. Examiner will appreciate that. He knows that you have a basic knowledge. You are progressing further up the ladder. Then in case of significant trauma, you think of dislocations also. So the possible dislocations in hip are anterior, posterior, and central. Very simple. But in these major injuries, don't forget to look for associated injuries. There are major injuries to the spine, calcaneae, knee joint, other things at multiple sites. So that is very, very important. Okay, now let us say a classical description of trivial trauma. The patient has a fall in the bathroom or slipped and fell. These things you expect, obviously. The teaching is fracture neck of femur. So simply patient is able to walk. It is probably impacted fracture neck of femur or no fracture at all. If the patient is not able to walk after a trivial trauma, it is fracture neck of femur. So easy to make a diagnosis by taking a proper history of trauma. Sometimes in late cases, suppose the trauma is of a very, very long back incident, so it usually brings up the attention of the patient towards the disease. So there may be an ailment which was in the childhood. Now the patient falls due to fall in the bathroom or something. Then he continues to have pain in the right hip. You take an X-ray, you find there is a old Perthes disease. So those kind of things are possible. So usually they bring the attention of the patient towards the disease. And sometimes there could be major also, like major happening inside also, like pathological fractures. But you must take which trauma has happened earlier and what was the treatment that was given to that trauma at that particular time of incidence. So that is extremely important in these cases of trauma. Suppose the patient doesn't give history of trauma, that is called as atraumatic or non-traumatic conditions. Then again, what you had in your mind already, in case of child, you think of these things like TB hip, Perthes, bilateral Sufian infections. In case of adults, you think of TB hip, AVN, secondary OA, primary OA, and septic arthritis. So if it is traumatic, you think of major trauma and minor trauma. If it is non-traumatic, you think of differential diagnosis in a child and think of differential diagnosis in an adult. So it's very easy once you have the knowledge of these things in your mind. You can slowly modify your examination technique as well as slowly come towards your diagnosis. I hope I'm clear. If you have any doubts, you can stop me in the middle and then ask me. You are most welcome.
Anybody, any doubts in the history? As far as history is concerned, all the especially exam going students, I think you can feel free to ask any questions to the sir. Sir has been a PG exam since a long time. And in a nutshell, what you have to think in the history is his story. Normally it is said that at the end of the history, you should be able to make a provisional diagnosis. The most of the things in the history, you have to think of the traumatic and non-traumatic conditions. Okay. If we think it's a followed by trauma, the diagnosis will be very easy. Okay. Again, in the non-traumatic conditions, you have to go along with as per the age group. So the patient is having a child is coming to you, adolescent is coming to you, adult is coming to you, an old man of 40 plus is coming to you. So that's all very important. When there is as per the age, you have to make a diagnosis. So these all things, it is called knowledge of the possibilities. Knowledge of the possibility depending upon the evidence is there. What is the evidence available there? Okay. And then we'll come later as we just progress with the other findings. So remember, this is the limb, painless limb or painful limb. As the limb is concerned, it is a painful or painless. There are a few questions for you, Raghunandan.
Sir.
Our want to know our PGs. Please tell differential diagnosis limb in adults and painless limb versus painful limb in adults. A little bit, both are written same. Painless limb in adults.
Okay, you want to know the conditions where you have painless limb?
Yeah, a differential diagnosis of limb in both children and adults.
Okay, sir. Okay. So painless limb, obviously in a child is a diagnosis of Perthes disease and Sufi. It's very simple. Painful limb in a child is diagnostic of tuberculosis hip. Or of course, septic arthritis, he cannot walk. You forget about walking, you cannot even move his limb. So patient will be bedridden. That's it, septic arthritis. So in a child, it's very easy to make a diagnosis. So it's either Sufi or Perthes disease if he has painless limb. If he has pain, it is tuberculous arthritis. And of course, nowadays we get different kinds of arthritis like irritable hip, those things. Anyway, for examination's sake, this is how it is. But I would always say one clinical sign, one clinical symptom is not going to give you a diagnosis. That's what very important. In orthopedics, you have to correlate your findings. So we have, depending upon your history, we have only certain suspicions in your mind. You should not dogmatically say this is the diagnosis, because it's very important in the examination. As you progress, you narrow your possibilities. I didn't say that you can make a clear-cut diagnosis after history. Very important. So you should not be dogmatic that this finding is there and my diagnosis is this, because as the examination progresses to the level of palpation and other things, movements and measurements, you refine your diagnosis and then you come to one or two diagnoses finally. So these are common things that you have in mind. In adults, if you think of a painless limb, the obvious cause will be, there will be a secondary sequela only. So obvious cause would be either a Perthes disease or an instability at the hip or a limb length discrepancy. As far as hip is concerned, These are the three common problems. So either a Perthes disease, old one, or a limb length discrepancy, or an instability. Instability means a posterior dislocation or a childhood DDH, or LLD means whichever has arisen because of old trauma like AVN, which is remodeled, or any head fractures and anything. So a painless limb in an adult is usually not kept for an examination. A painless limb in an adult is usually not kept for you in the examination. It is for our differential diagnosis that you must know, because almost all the cases which will be kept in the examination are usually associated with pain. So painless limb in an adult is a little bit more complex, and a lot of diagnosis will come, because the problem here is treatment. So you take a case of non-specific arthritis of the hip joint. The characteristic of non-specific arthritis is remissions and exacerbations, as well as patient will become symptom-free during the period of treatment. And again, he will continue to have symptoms. There may not be fixed deformities. There can be limb, and there may be final degrees of restriction of movement. So all these things, what I mean to say is you have certain things in mind, and probably at the end of your examination, I hope your diagnosis will be much more clearer. It is a little bit difficult at this stage to say that painless limb will stick to one diagnosis, painful limb will stick. Little difficult to state categorically at this stage, I believe.
Yes, Raghunandan. Yes, especially in the adults, it is very difficult because there
are little difficult, sir.
Umpteen number of conditions will come into consideration. Maybe a ununited fracture neck femur, and a ununited or malunited trochanteric fracture. There are so many things will come into differential diagnosis. So remember, in orthopedics, the diagnosis is sometimes made with a simple, without seeing the patient, you can make a diagnosis. Sometimes with the end of history, you can make a diagnosis. End of inspection, you can make one diagnosis. End of palpation. Sometimes you may need imaging. You may need advanced imaging, advanced investigations. So that goes like that. You cannot cut all the things into one box. It depends on the conditions. So certain conditions can be easy. Certain conditions very, very easy. Certain conditions, even at the end of investigation also, you may not be able to come to a conclusion.
Yes.
That's how the subject goes like that. Any subject. Okay. Sir, I think anyone to add, Sivananda, you want to add anything in the history?
Shivan. Hello.
Shivananda, anything you want to add in history?
Geeta, I think you are thinking about a painless limb. Probably you are thinking a certain causes for the children and certain causes for adults. What sir said is, in the adults, there are so many number, and you have to accommodate it with all the other findings. Then only you can make a conclusive diagnosis. But in children, definitely congenital dislocation of the hip and coxavara and Perthes, these will come into the differential diagnosis most of the times. So anything correction? Yes, sir.
DDH is correct, sir.
Yes, sir. Congenital dislocation.
Yes, sir.
And coxavara and Perthes disease, most of the times they come under differential diagnosis.
Yes, sir.
And usually the painless limb is that terminology reserved for children only, not for the adults.
Yes, sir. That's why by the time adult they reaches, they develop arthritis of all these conditions.
There are so many conditions.
So definitely, all these conditions become painful.
Yes, the ankylosing also will cause a painless limping. Simple ankylosis. Okay, right. Sir, please go ahead, sir. With your further.
Right. Okay. Now let us see what we make out by inspection.
1 second.
So in inspection, the most important thing is position in which the patient is examined. Usually students will have the habit of telling examined in various positions. They have all fancy positions in which they examine. But the most important thing, two positions to examine is supine position and standing position, obviously. So you cannot say examination from the side, from behind, all these things, they are not really comfortable for the examiner. You straight away go to your findings, and in which position you see them best, you can tell the examiner. The examiner will appreciate you. You cannot say from side I have seen all these things, from behind I have seen these things, from oblique I have seen these things. No need. You tell important findings. And you can say from side it was more nicely visible, something like that. So anyhow, the patient should be, if it is examined in a supine position, he should be lying in the position of comfort. So you must tell this word, patient is made to lie in a position of comfort. So if you see on inspection, certain diseases are telltale evidence. They become telltale when in certain positions, like in standing position. Let us see which diseases we can make a diagnosis in standing position. So an exaggerated lumbar lordosis is best seen in standing position from the side. It is exaggerated in obviously bilateral FFD, that is fixed flexion deformities, or bilateral DDH. Unilateral, I didn't touch here unilateral because we are talking about very severely exaggerated lumbar lordosis, which is just by standing alone, you can simply see it's completely exaggerated. So in these cases, these two cases, in order to maintain the parallelism of the limb, you know how it develops the kind of lumbar lordosis, all PGs must be knowing. So if you have a fixed flexion deformity of the hip joint, your trunk is flexed with relation to the hips. So how to make your trunk parallel to the hips? You have to exaggerate your lumbar lordosis. For a simple example, a child, which is the fetus, is born with an attitude called as universal flexion. So in case of a fetus, that means as soon as the child is born, the entire spine is in a flexion shape. That is called as universal flexion attitude. You know how the cervical lordosis develops? When the child tries to lift up his head, that is called as a stable neck. So in those times, he will develop a cervical lordosis. When the child tries to stand and walk, he will develop lumbar lordosis. Same way, in order to maintain the parallelism of the limb, the same mechanism applies here. So when the child is having a flexion deformity of the hip joint and still tries to become straight, then he will develop exaggerated lumbar lordosis. You make a diagram of it, you know better. So this is how to maintain the parallelism, the child will develop deformities like lumbar lordosis or other deformities around the hip joint. You see, for the scoliosis of the lumbar spine from behind, it is quite common in fixed abduction and adduction deformities. So kyphosis is seen in some diseases of the lumbar spine only. Scoliosis is seen in diseases of the hip joints usually. Exaggerated lumbar lordosis is seen in case of disease of the hip, mainly FFD and bilateral DDH. Then you examine for gluteal muscle wasting, which is quite common feature in case of infective arthritis. A trochanteric prominence is the most common finding in case of any given hip. We'll see it later. The person may have a stooped up posture, like bending of the trunk and bending of the C-spine. This is called stooped up posture. Scoliosis is seen in disease of the hip. There could be a limb length discrepancies and there could be a possible positive Trendelenburg sign, which are all the common findings that we make in standing position of the patient. So these are the common findings. If you tell to the examiner that I made this finding on a standing position, then he'll be happy. So standing positions are the important findings that you must not forget to tell to the examiner. When you look at the patient, if there is an exaggerated lumbar lordosis that we have made out on standing, we are not talking about the very severely exaggerated lumbar lordosis that we have seen earlier. So in case of exaggerated lumbar lordosis, when the patient is lying down or standing, then in case of certain diseases, it's going to be increased. So an increased lumbar lordosis for a case of post-guided examination is possible with a fixed flexion deformity of the hip joint. So where do you get fixed flexion deformity of the hip joint? TB hip, severe secondary osteoarthritis of the hip joint, and in case of dislocations. So an increased lumbar lordosis is diagnostic of fixed flexion deformity of the hip joint, which is common in these three conditions. But in certain cases, you cannot infer exaggeration of lumbar lordosis, like you cannot infer Trendelenburg test. So those are the conditions like old fractures of the lumbar spine, ankylosing spondylitis where the ligaments are at fault, inflammatory disorders of the spine where even the disc is involved along with the paraspinal muscles, disc diseases, and bilateral hip disease. So these are the common conditions where you cannot really infer whether the hip joint is in a fixed flexion deformity because the lumbar lordosis is already sometimes it is fixed or due to disease, you cannot infer exaggerated lumbar lordosis in those conditions. Then we move to the front, we see the anterior superiliac spine. Very simple thing, higher level, there is a fixed adduction deformity. Remember, fixed adduction deformity is the most common deformity around the hip joint. Lower level is fixed abduction deformity, which is very rare. So before you commit that lumbar ASIS is at a lower level, think twice. There are only few conditions in the hip joint which will produce fixed abduction deformities like anterior dislocation of the hip joint, which is unreduced, bedridden patients, and then end stage of the infective disease with capsular involvement. Ligament of Bijlani, when it is involved, they may produce. So fixed abduction deformity is very, very rare in the hip joint. So lower level of ASIS, you should not tell in the examinations. If you tell means you must have a substantial evidence of either of these. So higher level is most common because of fixed adduction deformity. You look at the attitude of the patient. So fixed deformities is different, attitude is different. So you understand, fixed deformities is different, attitude is different. Attitude is with reference to the entire lower limb. Fixed deformities we are referring with respect to only hip joint. Let us see how the example goes. So we are telling about the neutral and external rotation attitude of the hip joint. We talk about hip joint because we are obviously when you are telling attitude, you start with there is an exaggerated lumbar lordosis. Right antisuppiliac spine appears at a lower level. Right hip joint is kept in an attitude of flexion at the hip, flexion at the knee, external rotation, and then limb length discrepancy, whatever it is there, that you must tell. So this is how you describe the attitude. So if you describe an attitude of neutral position and external rotation, your diagnosis is either fractured neck of femur or traumatic fracture. So neutral position, that means there is no fixed flexion or extension deformity. A neutral position with external rotation, the most common diagnosis when a patient gives a history of trauma is ICNF or a trochanteric fracture. Then flexion, abduction, and external rotation. You know the diagnosis, it is synovitis or anterior dislocation of the hip joint. So they are not fixed things we are talking. This is just attitude we are talking about. Flexion, adduction, internal rotation, which is the most common attitude in case of hip joint that you get in a case of tuberculous arthritis and posterior dislocation. Mild flexion, adduction, and neutral rotation. Mild flexion, there will be very mild flexion, there will be mild adduction and neutral rotation. Usually you get in cases of primary arthritis and secondary arthritis, which is not very, very commonly kept in examination. So usually if they don't have major deformities in the examination, you think of secondary arthritis first, then you go to primary arthritis possibly as well, second diagnosis. Only abduction deformity that you get in a case of central dislocation of hip joint. So these are the common deformities. By looking at the attitude of the hip joint, you can make a reasonable clinical diagnosis of what it could be. Okay, on inspection, there is a limb length discrepancy. So if there is a limb length discrepancy, what could be your diagnosis? There are two things like apparent shortening and apparent lengthening on your examination. So when you talk about apparent shortening, so many of your clinical diagnosis will fit into apparent shortening. So any FFDs like fixed flexion deformities, severe arthritis, dislocations, congenital disorders, most often they fix into apparent shortening. But if you are telling apparent lengthening, then you should be very, very careful again. So because in case of very, very severe synovitis, it can happen. In case of anti-dislocations, it can happen. And if it is bilateral, bilateral shortening or bilateral lengthening, you cannot comment because it's difficult to comment unless you have seen the X-ray. So supposing there is a gross destruction due to bilateral Perthes disease, you already got a clue that it is bilateral Perthes and there is shortening, but still you cannot comment on your examination if the shortening is. It is only with respect to the opposite side that we are telling whether there is any shortening or that's why it's called as apparent shortening and apparent lengthening. So in comparison to the normal side, we are telling this. And then comes the Galeazzi sign. I need not elaborate on this. You know how to do a Galeazzi sign. You know how to suspect which component is shortened like femoral component or tibial component. Then we come to hip joint proper inspection. So we have seen the attitudes, we have seen the lumbar lordosis, we have seen the LLD. Then we'll come to hip joint proper examination on inspection. What could be the diagnosis possible? Look at this Karpaz triangle. If there is a fullness, which is little rare nowadays, if there is a fullness, you suspect cold abscess, anterior dislocation, or septic arthritis. Of course, they are little rare. But you must have in mind. If you are looking at greater trochanter, which is less prominent, the diagnosis is central dislocation. Which is more prominent, the diagnosis is usually posterior dislocation. And of course, other things are there, like coxa-vara, other things, but posterior dislocation is the common diagnosis because it will be little abnormally prominent in non-anatomical position. If it is elevated, so almost all your exam cases, almost all your chronic cases will fall into this category called as elevated greater trochanter. When you look at the muscles around the hip joint, if it is wasting, you know it's tuberculosis. If it is asymmetrical folds, you know it's DH. And if you look at myositis, sometimes you may have a red gluteal muscle, red-looking gluteal muscle which is swollen. Then you suspect myositis. Later on, if you put your hand, you'll know. But we are still in the stage of inspection only. So myositis should be in suspicion when you look at a angry-looking gluteal muscle. Then we go to palpation. I am not going to touch all the findings in palpation. I am going to touch only the ones which are of clinical and diagnostic significance. So we look at the tenderness. If the tenderness is there on the anterior joint line or posterior joint line, you think of infective pathologies and inflammatory pathologies. Obviously, it's a common sense. Look at the trochanter, feel for the tenderness. If it is superficial, you think of bursitis and osteomyelitis. If it is a percussion or a deep tenderness, you think of hip pathology. I think every postgraduate knows this. So superficial and deep tenderness. You look for a vascular sign of Nagaraju. So people have a habit of feeling for femoral pulse and then saying that difference is there between this femoral pulse and that femoral pulse. Simply put your hand over this Karpaz triangle. If femoral pulse is palpable to your hand, that itself means that vascular sign of Nagaraju is negative. If you are searching for the femoral artery, in Karpaz triangle, that itself indicates that vascular sign of Nagaraju is positive. So femoral artery pulsation is absent. It is not the vascular sign. Difficult to palpate the femoral artery or difference in pulse pressures on both sides is the vascular sign of Nagaraju. So if you are trying to search for the femoral artery, it's difficult to palpate. That means it's difficult to palpate. In those cases, it doesn't mean that there is absence of femoral artery. It is difficult to palpate. Then vascular sign of Nagaraju is positive. You know all the cases where it is positive. So like dislocations and Tom Smith's arthritis and where there is various possibilities. So an ease of palpation of the femoral artery is important here rather than femoral pulse volume and all those things. Then you go to trochanter. Trochanter has got 4 points, what is called as test, that is tenderness, elevation, surface and thickening. So test has to be examined in case of 4 points examined in case of trochanter. So tenderness, you know, other conditions we have mentioned. Trochanter is elevated in all cases, including coxa-vara, pethys, and then instabilities. It is neutral. Surprisingly, it is neutral in cases of avian. In cases of avian in the early stages at least, and then non-specific arthritis. So there is a neutral trochanter with pathology hip is possibly avian and non-specific arthritis. Look at the surface of the trochanter, which is irregular in case of other trochanteric pathologies and of course associated usually with thickening. So trochanteric fractures and osteomyelitis and very rarely chronic bursitis, all these things produce surface irregularity of the trochanter as well as thickening in the trochanter. So what are the other bony findings around the hip region? Apart from the exam, you have to examine all the other bony points around the hip. I'm not going to do that, cover that for you. If you look at posterior superior spine, which is indicated by the dimple of Venus, if there is tenderness, it's commonly suggestive and mostly suggestive of ankylosing spondylitis. There are two types of ankylosing spondylitis that you must be knowing, that Mary-Strumpel disease and von Westerhues disease. Mary-Strumpel is ascending, von Westerhues is descending. So it's commonly seen in Mary-Strumpel where the sacroiliac joints are most commonly involved first, then the calcification or ossification ascends up. If there is a fixed scoliosis of the lumbar spine, the That means the scoliosis cannot be obliterated or cannot be reversed. So in those cases, you cannot even infer Trendelenburg test also. So you should be very, very careful, and you cannot square the pelvis also. So in case of lumbar spine pathology where there is a fixed scoliosis like hemivertebra, so in those cases, you cannot infer Trendelenburg test, you cannot square the pelvis. Just remember that when you are looking for other bony findings around the hip joint. If there is an abnormal bony mass, you suspect two things, namely myositis or head. You know what is myositis? It is irregular, and then margins will be irregular, and it's freely mobile. It doesn't move with the movement of the shaft of the femur. In case of head, which is regular, ovoid, or hemispherical, and it moves with the movement of the shaft of the femur, confirmed it is a head. And of course, you search gluteal and adductor areas for dislocations like posterior dislocation and anti-dislocation respectively. Then you come for movements. The common problem that comes in the movements is obvious limitation of the movements, which is common in a hip case. Very, very rarely you get exaggeration. Some in cases of only a single direction exaggeration. The best example is Sufi, where the external rotation is exaggerated. So something like that. It's a different thing. So final degrees of movements are limited in synovitis. Concentric limitation of movements is present in arthritis. That is how you clinically differentiate between arthritis and synovitis. So in synovitis, only final degrees of movements are restricted. And in arthritis, all ranges of movement, at some or other degrees. I have made this diagram to show you that if there is it is illustrated by a ring. So flexion is limited by this much, adduction is limited by this much, abduction is limited only by this much, extension is limited by little bit more. So the degree of limitation is not a matter here, whether it is limited or not. That is a matter here. That is what is called as concentric limitation, not equal degree of limitation in all directions. It is whether it is limited or not in all directions indicates that there is a concentric limitation. So if there is some movement limitation in all directions, you can say it's a concentric limitation. So fixed deformities, I already explained you, they develop to maintain the parallelism of the limb. So supposing patient has a fixed adduction deformity. So fixed adduction deformity, the limb is towards the midline. So in order to make it parallel, the pelvis has to go up. Then only it will become parallel with the other limb. So upgoing antispinac spine will make the limbs parallel. That's why in case of fixed adduction deformities, there will be elevation of the ASIS. Let us go to Thomas test. So Thomas test, you all know how to do a Thomas test. I'm not really into that. Some observations I tell you regarding the degree of fixed flexion deformity. So if the Thomas test shows that there is a 60 to 70 degrees of fixed flexion deformity, which is little rare, suspect dislocations of the hip joint, namely posterior dislocation, or in very, very late cases of bedridden patients who have the habit of keeping their knees flexed and hip flexed and lying down like in paralysis. If it is 20 to 40 degrees of fixed flexion deformities, then you think of all your clinical cases that you get in the examination like tuberculosis, rheumatoid arthritis, or ankylosing spondylitis, kind of things. In case of hip joint, there are two involvements like, let us say tuberculosis. It involves synovium as well as bone. When the synovial involvement is primary, that means synovium is involved first, the deformities are earlier. Because the synovium is more connected to the soft tissues, deformities are earlier, like in case of tuberculosis and rheumatoid arthritis. When the bone involvement is primary, like bony focus of tuberculosis kind of things, like an example, osteoarthritis or avascular necrosis, deformities are little late. So synovial involvement, deformities are earlier, bone involvement, deformities are little late. Bilateral FFDs, bilateral fixed flexion deformities, standing and walking are characteristic of DDH, ankylosing spondylitis and rheumatoid arthritis. So which are little rare for you to be kept in the examination. So anyhow, I told you already the limitations of bilateral FFDs, how you cannot make out those things. When you look at the squaring of the pelvis, before testing for a movement, you do what's called as squaring of the pelvis. The squaring may not be possible. So you try to do a squaring of the pelvis, which is not possible. So the conditions where you cannot square the pelvis are fixed scoliosis of the spine, like example is hemivertebrae, ankylosing spondylitis, when entire spinal column is frozen, Severe lumbar spondylosis in case of old people where they have multiple osteophytes called as lanceolate osteophytes, which are pressing over the ligaments and producing the paraspinal spasms, everything. Acute disc, which is again a painful spasmatic condition. Severe spine infections, and then spinal trauma. So in these cases, squaring of the pelvis is not possible. So you should be very, very careful in telling about the squaring of the pelvis in these cases to the examiner. When you tell about the movements, you must give the start range, you must give the active end, then you must go to the passive end, and you must tell the range. Let us say from, I will tell you, from 10 degrees of fixed flexion deformity, flexion active is possible up to 90 degrees, which is painless. Further flexion is painfully limited. Okay, you understand? So all the things are covered here, like starting time, starting range, ending range, active, painless, further painful, and then end, that is restricted. So what is the range here? 20 degrees to 90 degrees was the flexion. So range is 70 degrees. So you must know what is the starting and then range and then active end, passive end, mix it with the pain plus or minus. So you must tell the examiner like that. Then you come to measurements. So you have two types of measurements, namely apparent measurements and then layered measurements. So apparent measurements includes the soft tissue component that you must all know. The position of the patient is patient lying in a position of comfort. So he has some flexion at the hip, flexion at the knee, some deformity at the ankle, all these things included is your apparent shortening. So ask the patient to just lie down and then take a measurement from Ziphis sternum to medial malleus. You do not ask him to do any maneuver. You do not ask him to do any correction. Simply take a measurement that gives the apparent measurement. Of course, true, you know, only bony measurement, it gives you have to keep the limbs in identical position or symmetrical position or mirror image position, what is called as, then only you take measurement because you are trying to exclude the soft tissue component by keeping the limbs in mirror image position. You are trying to take only true bony measurements. That is supratrochanteric in case of narrowed in case of elevated trochanter, infratrochanteric narrowed in case of involvement of the shaft like shaft fractures, small unions, all these things. Then we go to Trendelenburg test, which is commonly done, which is commonly described, and every student knows how to do it. So you better do it in a standing position. You better observe from the front because the bony points are more clearly marked and you are anyway marking the anticipulac spine. So it's very easy to observe from the front. So the prerequisites for a Trendelenburg test, you all know, 30 seconds, this, that, and all I'm not going to tell. So you cannot infer Trendelenburg test in certain conditions like fixed adduction deformity. When there is a fixed adduction deformity, of course, a very, very large fixed abduction deformity also you cannot make out. But I told you before committing fixed abduction deformity, be very, very careful. There is nothing much, not many cases present to you with fixed abduction deformities. So fixed adduction deformity you cannot measure. Severe flexion deformity you cannot infer. Acute hips where a patient cannot stand. Spine diseases where again the patient cannot stand or may have a neurological deficit. Or bilateral hip affections which you cannot infer. So all these things you must know. You know what is called as assisted Trendelenburg test. You know what is called as a delayed Trendelenburg test that happens in muscular weakness conditions like let's say poliomyelitis and gluteal nerve injuries, all these things. So anyhow, Trendelenburg test cannot be inferred where that you all should know. Telescopy, when you try to pull the femoral condyles from the greater trochanter area, that means entire femur, you have to pull it up. You can have this positive sign in unstable hip, IC non-unions and DDH in palm smiths, where the head is not there in the sternum. So that is classical of Trendelenburg test. But in certain cases, you may not have a total head coming out of the sternum. In certain cases, let's say in the IC fracture non-unions, when there is some amount of neck, you will have a sense of yielding. You try the normal side first. It's very tight. It will not move so much. You may have some sense. But on the other side, there is a definite sense of what is called as yielding. That means the gap you appreciate is going to increase between your fingers and the greater trochanter. By pulling your femoral condyles with the opposite hand, then there is a sense of yielding that indicates that possibly there is some pathology or instability at the hip joint. Okay, all said and done. We come to our provisional diagnosis. So we must have an ideal case findings. So all in all, I understand the diagnosis is already given to you most of the times. All the postgraduates know what is your diagnosis. So I suggest my postgraduates that let's say TB hip case is given to you. So you must have already got the idea that it's a TB hip case is a fixed flexion deformity. Okay, fine. So in that cases, you must know what are the ideal findings in your case. Let us say history. There should be a remission, there should be a fever, there should be constitutional symptoms, there should be night cries. On examination, there should be apparent shortening, there should be a fixed flexion deformity. ASIS must have gone up, greater trochanter findings shall be there. And then there is a Thomas test positive, and then squaring of the pelvis done, there is a fixed adduction deformity. And then moving the hip, there is a restriction of this, that, and then probably there is a spinal ankylosis. There will be apparent shortening, and true shortening is the supratrochanteric. And there is positive Nelitans, this, that, everything. So you must have ideal case sheet. A case is given to you. So you write all the ideal findings first, separately in a small paper. Then you prepare your case sheet. Whatever you have seen, whatever you have examined, all these things. And try to correlate whether those ideal findings are there in your case or not, which is very important. Okay, there is a controversy. Let us say tuberculosis case is given to you. You think there is an anticipolar spine is at a lower level. But ideally, it should be at a higher level. Ideally, it should have a fixed adduction deformity. Then if it is at a lower level, then there is a controversial finding. Now you must try to correlate it. It may be correct. You may be right. But you should try to correlate it. That means you must think, okay, this is tuberculosis hip. Ideally, this should have had a higher up ASIS. Why it is lower? Can I explain it? If you can explain it, it's well and good. If you can't explain it, for the exam's sake, write an ideal case sheet only. If you can't explain it, okay? So that is very, very important. So if you are a good student, if you are confident enough, then you can explain to the patient that patient was lying in a supine posture for quite long a time, sir. There may be possibility of involvement of visual. So that's why there is a little bit of external rotation deformity is there, and then there are no fixed adduction, something like that. So you should be able to explain to the examiner that what could be the cause for these controversial findings. So anyhow, try to make them as ideal as possible. And then you must see whether it's a traumatic case or non-traumatic case, whether it's an infective case or inflammatory case, that you must have in mind by the time you complete your examination and offer a differential diagnosis. And then try to correlate your clinical findings. That's what we were discussing earlier. Try to correlate. If there is a controversial finding, either you delete it or try to explain it. That's very, very important. And of course, you must have a other reasonable differential diagnosis in mind. You dogmatically do not go with a simple, by saying that I have heard to the lecture, this should be this only. You cannot tell to the examiner like this. It will be a little flexible and try to offer a reasonable differential diagnosis. Okay, with this, we come to the examination of hip joint. I would now go to some typical case histories and case findings. Let us see how easy for you it is to make a diagnosis in our next section.
I think we can ask some questions here. And any doubts at this stage? Balkrishna Naidu, just ask your question.
Good afternoon, sir.
Please.
Is telescopy test can be done if flexion of hip is not possible?
Yes, definitely. Why not? See, telescopy is basically to create a distance between your finger and the trochanter. That's it. That means whether the hip is yielding at the level of joint capsule or not. I tell you that mandatory flexing of the hip to 90 degrees is possible only in certain cases. See, in most of the cases, you may not be able to flex the hip to 90. In those cases, ideally, you have to keep the leg on your shoulder. Entire lower limb is to be kept on your shoulder, and you try to move front and back. So the limitation here is not the question of flexion at the hip. The idea here is whether it is moving away from your fingers or not. So in extension also you can do it, but it's not possible, to separate so easily in the extension. So obviously you have to flex the hip. If it is totally extended, so when it is ankylosing spondylitis, when there is a total stiffness of the hip, you cannot do telescopy. So telescopy is basically inside the hip what is happening. If something is really happening outside the hip, it is not useful. let's say an example of ankylosing spondylitis going for calcification of the capsule, you cannot infer telescopy. It's not possible. It's not possible. So flexion, yes, 30 to 40 degrees is enough to do a telescope.
Thank you, sir.
And certain times you can keep over a, I've seen people performing over a sandbag, you keep the knee joint. So make the patient rest over the knee, over the sandbag and try to push and pull your femur. You can do it still.
Thank you.
A little bit controversy is there, Raghunandan, at this, regarding this point. Even recently I attended one IOA PG teaching course at Pondi.
Sir.
There one senior exam is just against doing this in 45 degrees flexion. I totally agree with you. It is only that we are testing the instability.
Yes, sir.
Of the hip joint.
Yes, sir.
So I think, as you said, the full extension may not be possible. I think we can definitely do in 45 or 60 degrees flexion.
Yes, sir. Definitely, yes,
It's not really mandatory to do it always in the 90 degrees flexion,
yes,
as
sir.
described in the textbooks.
Yes, sir.
Maybe originally it may have given a diagram like that, but I feel that definitely we can see how much we can pull this apart from the joint.
Yes, sir.
So that is the one controversy, Raghunandan. So I think as now, because there will be controversy in the hip joint. In suppose some centers they do in a different way. And in recently also I had in Pondicherry, but vascular sign of Narathis, that fellow is included in the special tests.
Okay.
I told them it is not a special test, it is a part of the palpation.
Yes, sir.
The palpatory findings. It is never a test.
Special test.
Another special test, I am really surprised to mention, SLR, it is another special test.
That is recently added, sir. That is recently added in.
Unrelated, because we read many fancy textbooks, so that is the problem.
Yes,
but
sir.
you may read any number of textbooks, but you have a logic in that sense.
Yes, sir. Yes, sir.
We should have a logic. Simply somebody write like that, you should not follow that. Any more questions from the students? I request all of you, please feel free to clear all your doubts, because most of them are the exam going students now. Don't have doubts in the examination. Because we are the senior examiners are here, try to clear your doubts. And another thing, because no one is coming out any questions, I would like to add a few points in the discussion what has been taken place so far. So in the hip joint, all the deformities are concealed or compensated rather. In all other joints, all the deformities are revealed. The purpose is already, Sir has told you, the parallelism. Because you have to bring both limbs parallel to the one another. Otherwise, you cannot sleep, or you cannot sit, or you cannot stand. Again, when you're walking also, you cannot keep the limb in abduction, cannot walk. You have to bring it down. So all the deformities are compensated only to bring the both limbs parallel to one another, and also to reach the ground while walking. That is the two purposes of compensation. The compensation occurs in two planes. One is sagittal plane, where the flexion deformity is compensated up to 30 degrees by the lumbar lordosis. That is the amount of flexion a lumbar spine can offer. Beyond that, it is revealed. Again, all the coronal plane deformities are adduction deformity, wherein the pelvis goes up, and the abduction deformity pelvis comes down. That the coronal plane deformities are compensated. Again, the pelvic tilt compensates to just bring one another to parallel. Okay. Then third thing is, remember the rotations are never compensated. That is the reason why I insist, I tell all my students, while checking rotations, there is no need for you to fix the pelvis. Very difficult to fix the pelvis and do the rotations. So many of the examiners, old time exam, they insist that you should keep a hand on the pelvis and rotate. You can't do it. Literally, it is not possible, because you have to hold the thigh and the leg, then rotate. So very difficult. So always without two hands, you cannot rotate. So I feel personally, there is no need for you to fix the pelvis while checking the rotations. Okay.
Yes, sir.
Yes.
Agreed, sir.
If you do it in a more vigorous way, different, whole body will be tilted, not only pelvis. Okay. That is not warranted. We should not do that. Okay. That's what I want to give the message to all the students, because in the exams again they get confused, right? So another point, Raghunandan, I would like to clarify from you, and the Shivanand also if he is there. So we always tell the students to tell the diagnosis and what is the anatomical diagnosis, what is the etiological diagnosis, what is the pathological diagnosis, what is the clinical diagnosis.
Yes, sir.
There are 4 components of diagnosis. Most of the times we can tell the etiological diagnosis, anatomical diagnosis, but there will be some difficulty in pronouncing the pathological diagnosis and the clinical diagnosis. Can you give any clarification on this as your perception of these 4 components of the diagnosis, Raghunandan?
Obviously, sir, we have 4 components of diagnosis here. One is what is called as regional, that is anatomical diagnosis. Second is what is called as etiological diagnosis. Then what is called as pathological diagnosis. And finally, complications. So let's say I give an example of chronic. Let's say we'll pronounce a normal diagnosis, how we give in the examination. Chronic, specific, infective arthritis of the hip, probably of tuberculous origin, of right hip, let us say, with fixed flexion and adduction deformity. So this is how it is. So you have to give anatomical and then etiological, what pathology is there, what is the complication that you have seen. So let us say, otherwise also you can say tuberculous arthritis of right hip with fixed flexion and axial notation deformity, something like that. Directly you can give, or you can split into components, you can give, sir. But all 4 components have to be mentioned in the diagnosis, sir. But in order students not to get confused in whatever way they are used, they better give the diagnosis, sir.
Yes,
but
yes.
let them mention that it should be a complete diagnosis, not a simple TB arthritis right hip, they cannot say. They don't even say that. They say TB hip, they will say. See, all these things should not be done. You must give a proper phrases there. Of course, they may be mixed this way or that way, but you must give all the things. Tuberculous arthritis, hip, which hip, right or left, with associated complications. All these things should be mentioned, sir. It's a little confusing, I agree, sir.
Yes, sir.
But still, our components should be there when you make a diagnosis. At least when you are writing, you will get that rhythm. When you are writing, you get that rhythm. So try to remember that and try to tell like that only to the examiner. Don't tell simply like TB hip, right side. So you have to tell all the components. Sometimes there can be fibrous ankylosis. That also you have to mention. So complications should be mentioned last: anatomical, etiological, pathological, and complications. That's the order we go, sir.
If the students can remember all these components, I think they can at least mention 3 of the components.
Yes, sir. Obviously,
So always,
whatever they are comfortable, they can mention, sir.
It is always something like a suppose there is secondary osteoarthritis.
Yes,
You can mention there is a secondary osteoarthritis, the hip
Yes,
joint, right hip joint, right hip
Yes.
joint. Always remember, mention the side.
Yes, sir.
Most probably due to avascular necrosis.
Yes, sir.
Currently, patient is disabled by limitation of movements, difficulty in walking, and you can add that disability. The current disability is always has to be mentioned. Most of the examiner, they insist on the current disability. So anatomical, etiological, what is the pathology, what is the disability.
And I find students nowadays, they are telling a 65-year-old man came with the complaints of something like that, they'll start in the diagnosis.
That is
not at all nice. You must tell, ask the examination, the examiner will ask, what is the diagnosis? You cannot again start that 65-year-old came with the complaint of pain in the hip on examination. That is called a summary. Summarize your findings means you must tell from the patient, starting from the history, what are all the important positive findings you tell, only positive findings you tell, and then that's called a summary of the examination. But in the diagnosis, don't do all those things. Straight away go to your diagnosis. You can tell them, sir, I have 2 differential diagnoses in mind. My first probability is this. My second possibility is this. That you can politely tell to the examiner.
So summing up the findings is an art, please remember. And also don't carry it out by the diagnosis which is told to you. The problem is that in the exams, what happens, already you know the diagnosis.
Yes,
and you're trying to match all your findings to that diagnosis. Don't do that.
Yes, sir, that's the problem.
You be honest. You mention what are all your findings. Your diagnosis may be wrong. Something may come differently from a diagnosis in the X-ray. Don't worry about that. Always being an examiner, we appreciate your honest findings. come whatever may be the diagnosis. Even I don't see the X-ray before in the examiner, any examination also. I go there, any teaching program, as an examiner, I never want to see the X-ray first. I always go by the findings told by the student. I will believe that. I never want I want to see the X-ray. Because you will be biased. And the examiner will be biased, student will be biased, everybody will be biased. Then you are likely to commit the mistakes and blunders. So don't do that. So that's what my appeal to all the, I think most of the students are exam going now today joined. So please do that. You go as per the diagnosis, you create an evidence for that. Justification for your diagnosis. So that is the one. So you remember anatomical, etiological diagnosis, and then pathological diagnosis is possible, clinical diagnosis, and the current disability. And please remember again, you make this very simple. It is a traumatic or non-traumatic. And then also make it further simple, whether this is a head disease or a joint disease. Very simple fact is that in clinical findings, head diseases, usually they allow certain range of movements. Okay. Maybe, of course, in advanced stages, all the global restriction may be there. But usually, they allow certain range of plainness free range movements. Okay. Maybe abduction, adduction may be lost. And then the head disease, what I mean by head disease, they had deforming conditions like a Perthes and a Skiffy and other condition which deform the head. And then arthritis will come at that stage. So it's a primary arthritis like a septic pyogenic arthritis or a tuberous arthritis or a rheumatoid arthritis. There will be totally different scenario where you have a global restriction of movements. Okay. One word in the global restriction of movements. Again, in the severe osteoarthritis also, you may have some amount of painless free range because osteoarthritis is a patchy osteoarthritis. Some amount of normal cartilage may be left there. There you are likely to get some amount of free range of movements. That's the only arthritis usually allows you some range of movement. The other extreme of, in spite of the severe arthritis, you may have a normal range, painless range of movements is one neuropathic arthritis. Please remember that also. Where the gross destruction is there, but still patient can have a painless, full, abnormal range of movement, disproportionate range of movements. That is the neuropathic joint. Please remember this. So that's how you can make your diagnosis simple, but don't try to make it a shortcut. But this is only the approach we are giving how to approach make a diagnosis. Right? I think with this, I think examination points and making a diagnosis, pronouncing a diagnosis is not a difficult one now. So now I think move on to some case examples Sir has prepared. Then how they present. I think Sir, Raghunandan Sir, you can proceed now.
Yes, sir.
Shivananda, anything you want to add, Shivanand?
Sir, I don't know whether it is right or wrong, but most of the DNB examinations, they include age, sir. Why? Because age dictates the treatment. Age dictates the treatment.
You mean in the diagnosis, sir?
In the diagnosis, sir. Okay, sir. Most of the DNB examiners, age dictates treatment. Age and disability, these two are very important because disability will tell you what treatment we should offer to that particular patient. So even the patient is having intercapsular fracture neck of femur old, sometimes patient may not want any management. So he is comfortable with that. So what is the desire of the patient and what is the disability of the patient also we must mention in that particular diagnosis. I think age is that will dictate the treatment. So that's why it is better to mention the age. That is the, I think. I don't know, sir, whether it is right or wrong, but this is commonly going on in DNB examinations. Sir, please clarify, sir.
Yes, what is the doubt, Sevan? Sorry, I forgot it. Sorry.
We are not including the age of the patient in the diagnosis.
Okay, right.
In the diagnosis.
Okay, right. So that you have to customize the treatment to the age of the patient. That's what
age of the patient.
Age and disability.
Age and disability. So both the things should be mentioned in the diagnosis. That will give a better impression, I think, sir. I don't know whether I'm not a regular thing. examiner for the DNB students. So that's why I don't.
There's one question for you, Raghunandan. Sir, please tell how to fix the pelvis while checking for range of hip abduction in bilateral hip pathology cases, sir.
That's what you cannot, sir. You cannot infer. You cannot square the pelvis in bilateral hip abductions, sir. It's not possible, sir.
It is not.
Then have a fixed hip movement.
And dear Ashok, there is one for everyone. While checking abduction, very easy to check abduction in a provided other hip is normal. The one way of checking the abduction is take the normal hip into the extreme abduction. Normal hip into extreme abduction without tilting the pelvis. Okay. After squaring the pelvis, without tilting without moving the pelvis, just to take the opposite hip into extreme abduction and keep it there. That is what is called locking the normal hip in abduction. The locking, that is called locking. Then start checking the abduction on the diseased side. Suppose there is a 20 degrees abduction, then up to that 20 degrees, the other limb will not move. Beyond, suppose you want to move the abduction further beyond the deformity of 20 degrees, then the other rib start adducting. That's one way of checking the abduction, easiest way. So there no errors will be there. That is what is called locking the other limb in abduction and checking the abduction on the diseased hip. That is one way of doing the abduction movement. Then before going into case scenarios, Sir Raghunandan sir, we have not mentioned the gait. Can you simply tell how to check the gait of the patient, sir? Otherwise, you will have a class, one more class on the gait.
Yes, sir.
We are
better we have, sir, because gait is too complicated.
So remember, yes, everybody, you have to two things remember in the gait. Don't get confused with all these gaits. Whether you have to observe whether it's a painful gait or painless gait. Number one point is important. Then is unstable gait or stable gait.
Stable.
Okay. Then the third thing is another fifth one is the short limb gait. Okay. These 5 things remember: painful, painless, stable or unstable, and then fifth one is the short limb gait. And there may be combination of these gaits will be there. Don't get confused. In the exams, please remember this. This is more than enough, I think. Anyway, we are going to have one more class on exclusion and gait. I am going to conduct one exclusively on gait only. But remember, these 5 gaits are more than enough for you in the examination. Okay. That don't get confused with all other gaits. There are empty number of gaits are given, but don't get what the latch, what swing, the sway. Don't worry about that. But remember the principles of unstable gait, 10 number gait. What the principles are very important. That is very important. Unless you have adduction and abduction movement of the pelvis on the head, you cannot test the 10 number test. That is very important. So in the fixed coronal plane deformities, we advise the students not to test for 10 number gait test. Sir, I could not do it because the patient is having fixed coronal plane deformities. Sir, I could not do it because patient cannot stand on the limb for more than 30 seconds to 1 minute. Or you can test for assisted 10 number. There are only to know that how you have what approach, how we are approaching the diagnosis. That's what the exams are interested. Okay, that's all makes you how to give a marks to you, not to pass you. It is only to grade you. Your rating will depend on the method of examination and the interpretation of the findings. I think, Sivanand, I think this will clarify.
Sir.
Then, sir, you proceed the scenarios, sir, case scenarios.
Okay, thank you, sir. And I wish this should be more of an interactive session. So all of you, please unmute your mics and then try to participate in the few coming slides. So all of you unmute your words.
Open your videos, please. At least try to unmute yourselves and then try to participate. Please feel free. You're all your own faculty only.
So you have to tell me, I am not going to talk, you are going to talk. Okay. So unmute yourself. All of you. Even if we don't see you, you better unmute. That's all. You just let us hear your voice.
Open your, unmute yourself. No need to show your video. If you want to talk, you can show your video.
You can unmute. Okay. Okay, all right.
Also, Kishore also have to be very active today.
Okay, all right. Because this session is for you, because there are certain case scenarios. If you extract a proper history, how easy it's for you to make a diagnosis, we'll see. So, history number 1. Okay. So, now we are talking about a child or a young adult, that means a child basically, who has got a constitutional symptoms. So, what could be the diagnosis?
Tuberculosis of hip.
Yeah, obviously it could be a tuberculosis of the hip, or it could be a septic arthritis, something like that. So a simple thing like constitutional symptoms, which is again confounded by your history of night cries. Now, what is your diagnosis?
Tuberculosis.
So even before touching the patient, you could make a diagnosis of tuberculosis arthritis. Then we go for newer points, some good points like which are supposed to be there in a patient, like lordosis is exaggerated, antisupplex spine is at a higher level, there is an apparent shortening. So these are all the common classical findings that you are supposed to get in the patient if it were to be a classical tuberculosis arthritis. Flexion, adduction, internal rotation, or sometimes lately external rotation, and then concentric limitation of the movement. And if it is less than 5 degrees movement, what do you call that? If it is less than 5 degrees movement, which is painful, it is called as
global restriction.
Not global restriction, it's called as fibrous ankylosing. So there is only just a jog of movement, which is painful, especially in the case of tuberculosis arthritis, you call it as a fibrous ankylosing, which can also happen in rheumatoid arthritis. And of course, there is a supratrochanteric shortening, and the classical diagnosis is tuberculosis arthritis hip with fibrous. So this is how a classical picture of tuberculosis arthritis will fit in. If the type of constitutional symptoms and night cries. Let us take history number 2. Here is a child again, so you will have certain things in mind. The child has got a painless limb. What is the diagnosis?
Skiffy.
Very good. So it could be either SUFI. So by extracting a simple point in the history, you could very easily narrow your diagnosis between 2 possibilities, namely SUFI and Perthes disease. So there is a mild tenderness in scarpa triangle. There is no fixed deformities. There is restriction of abduction and internal rotation, which is classical of both. No major limb length discrepancies, and the chain looks relatively normal. It is Perthes disease. Okay, so the diagnosis is very clear. In case of history number 3, the same child who has come to you with a painless limb, now he has become an adolescent. There is pain, sometimes plus or minus, depending upon the acuteness. If it is acute, it may be painful. Chronic, it may be painful. And there is obese child who is looking endocrinologically abnormal. The diagnosis is
Skiffy.
So proximal femoral epiphysis slip. So the very easy to make a diagnosis by noting down a history. You must inquire whether there is history of trauma to show it whether it's an acute slip or not. So on clinical examination, there will be tenderness in the scarpa's triangle. There can be a trochanteric elevation, and there is the classical sign, what is called as flexion axis deviation. So when you try to flex the knee towards the same shoulder, it will go. It cannot go towards the opposite shoulder. Usually, when you try to flex the knee, you can carry it towards the opposite shoulder. That is called normal. You cannot go to the same shoulder. You can go to the same shoulder rather, but in the case of Skiffy, you cannot go to the opposite shoulder. It's not possible for you. You can only drag it to the same shoulder. So this is called as flexion axis deviation, which is a characteristic sign in case of SUFI. Abduction internal rotation is reduced. There is exaggerated external rotation in these cases and the diagnosis is SUFI. Then we go to history number 4. Still again, he's a child who has got a painless limb, like Dr. Shivananda sir was telling, and they report it is congenital. So what could be the diagnosis? DDH. So obviously it's a DDH case, developmental dysplasia of the hip joint. So don't say congenital dislocation. Now it is called as only DDH. So DDH is the diagnosis. Then you can see all the positive findings like, so I'm mentioning only important findings here, which are diagnostic of that particular disease. So other things are there because this is not a hip joint examination class. I'm not going to details of examination. So there could be a positive galeology which shows LLD. Vascular sign of Narath is positive. Usually there are no fixed deformities unless it is very, very late. Telescopy is positive. Trendelenburg is positive. And the diagnosis is developmental dysplasia of the hip joint. So 4 things we have covered by simply looking at the history and making a few points on your examination. Then we go to other age group like adult or young adult who is middle-aged. So adult, middle-aged, certain diagnosis should come into your mind. Again, the onset is chronic. There could be an old trauma. The important catchy point here is alcohol or drug in use, possibly steroids. So what is your diagnosis? So it's so simple. It is avascular necrosis of the femoral head or the hip. So it can be involving both one hips or 2 hips. And on examination, the classical points to elicit are tenderness in the Harpas triangle, no clear fixed deformities, at least in the earliest stages. Faber test is positive. Sectoral sign is positive. Limitation of movement, that is concentric limitation is there, but is some or other movement if it is a late case with secondary arthritis. And the diagnosis is avascular necrosis of the head. We are talking about primary avascular necrosis in early stages in this case. So it's very easy to make a diagnosis. In history 6, we have an adult female who is bilaterally symptomatic. The diagnosis is what? Adult female complaining of bilaterally symmetrical joint involvement. Rheumatoid arthritis. Obviously, when you take a female, certain things have to strike in your mind. Of course, they can be used. Doesn't mean that she will not have tuberculous arthritis, but common things first. So use your common sense first. So the common thing what they present is usually females. Naturally, they will use search for multiple joint involvements. There could be constitutional symptoms. The classical feature of that you have to elicit is remissions and exacerbations, and early deformities and pain, early morning stiffness are the classic features of rheumatoid arthritis. And on clinical examination, there will be more tenderness, more swelling, and sometimes there will be nodules. Usually, in limb length discrepancy will be very rare, except for apparent. There will not be any true shortening in the middle till the middle stage of the diseases. And then deformities are more common because I told you it's a synovial disease. There will be early deformities, concentric limitation of movements. The diagnosis is what is called as rheumatoid arthritis. Suppose in a case of history of 7, then we take an adult who is middle-aged. Again, something should crop up in your mind. Their history of constitutional symptoms is present. An adult who is presenting with history of constitutional symptoms and also with pain, usually single hips, then the diagnosis is a little bit trickish here. So you cannot usually suspect tuberculous arthritis or septic arthritis in an adult. So you look for other signs like tenderness, fixed deformities, plus or minus. There could be trochanteric findings like mild elevation. And the important feature is concentric limitation. So a unilateral adult hip which is inflammatory or infective, usually inflammatory because we don't think of infections, with a concentric limitation will point out that there is a hip arthritis and there could be a possible fibrous ankylosis in this case. So you think of tuberculous arthritis. So an adult tuberculous arthritis is little bit rare, but we think of middle-aged and adolescents presenting with this kind of scenario, excepting children. Constitutional symptoms with single hip, concentric limitation with fibrous ankylosis. Whenever there is fibrous ankylosis, you commit a diagnosis of tuberculous arthritis hip or very, very rarely rheumatoid arthritis. So you will be almost always correct. So in adult who is middle-aged again, that means little bit more. We are not talking about young adults here who is middle-aged. The pain is chronic. History of on and off treatment, which is very, very characteristic of one particular disease called as non-specific arthritis. So, which is a little bit uncommon nowadays, but examiners want those possibility of a differential diagnosis of non-specific arthritis. So, history of on and off treatment is very important. No constitutional symptoms, Sometimes it is associated with pain, limp, and stiffness. And on examination, no LLD, no fixed deformities, and mild concentric limitation of range of movement. The diagnosis is non-specific arthritis of hip, which is not easily clinically diagnosed. The clinical diagnosis is more of an exclusion rather than a straightaway diagnosis. So you must know what this condition, and you can offer a diagnosis, and all the other conditions are excluded. So this is the diagnosis by exclusion. Don't forget it. History number 9, an adult. So we are talking about older age group now. Occasional constitutional symptoms are present. Multiple asymmetrical joint involvement. So various different joints are involved. Other systems are involved. Other systems are involved, like he may have respiratory system involvement, cardiac involvement. And the patient's important complaint is postural disability or stiffness of spine. So what could be the possible diagnosis? When you elicit this finding, this is obviously ankylosing spondylitis. So elicit this one important finding. Other findings may be confusing to you. So this one important finding, which can be again substantiated by your chest expansion measurement as well as Schober's test, you can make a clinical diagnosis of ankylosing spondylitis. So other important things that you have to search in this case is a diffuse tenderness over the hip and over the body, over the spine and other joints. Mild fixed deformities are present because of extracapsular involvement. Gross restriction of range of movement because of, again, extracapsular calcification. Spine and chest findings will be present. The diagnosis in this case is ankylosing spondylitis. So a correlation between the final findings is very, very important. We are talking about a few catchy points that you can make in the history taking as well as in the examination to confirm to your clinical diagnosis. So this is a case of old age adult who is having bilaterally symmetrical joint involvement. An old age bilaterally symmetrical involvement and weight-bearing joints is diagnostic of osteoarthritis. Very, very easy. So knee joint, the clear case is osteoarthritis. In hip joint, I would admit it is rare, but a weight-bearing joint involvement which is symmetrically involved is pointing in favor of osteoarthritis. So there can be pain. Usually there are no fixed deformities, and there could be usually no LLD unless it's a very, very advanced stage. Concentric limitation of movement should be there because we are calling it arthritis, and then the diagnosis is what is called as primary osteoarthritis of the hip joint. In case of history number 11, in this case, if you see, he is an adult because he is a elderly age group. Unilateral hip, usually it's a unilateral hip, that is side is involved. And there is old history of involvement of either pain or limp because of trauma or a disease. So what could be the diagnosis in this case? An adult? Yes, secondary osteoarthritis. So obviously it's either a deformed head or an injured hip, which he had in the earliest history. Now he is complaining of pain, which is after a gap of at least 10 to 15 years. And occasionally old significant trauma will be there. There will be a very, very prolonged course. It is not acute or chronic. It's a very, very prolonged course with a significant disease-free interval in between. So symptomatic in recent period only. The diagnosis is more in favor of a secondary osteoarthritis of the hip. The most important findings, again, you have to elicit is tenderness, less severe fixed deformities, concentric limitation, because we are calling it as arthritis, there should be a concentric limitation. Signs of primary involvement like lessened abduction and internal rotation, exaggerated external rotation, case of Sufi, all these things point out that it is a case of secondary osteoarthritis of the joint because we are talking in adult age. In case of history number 12, he is an old age patient which has got a trivial trauma. So we are talking about just trauma which is recent, and then trivial, the diagnosis is trauma. We are talking about trauma and possibly it is a traumatic case. So it could be a pathological trauma or it could be a simple fracture neck of femur, obviously. Unable to get up, that means it's a significant fracture, probably. There could be a break in the bone. Obviously, it could be a major like ICR, EC. No major deformity. If it were to be a trochanteric fracture, there will be a major deformity. If it were to be a dislocation, there will be a deformity. No major deformity points out more in favor of a fracture neck of femur. Moderate external rotation. Again, this finding is in favor of fracture neck of femur. Able to internally rotate actively. If ask the patient to rotate internally the entire lower limb, she will be able to do it. This is one point which is diagnosing or differentiate between the fracture neck of femur and trochanteric fracture. If the patient is able to actively internally rotate the limb, which indicates fractured neck of femur. If the patient is not able to internally rotate the limb actively, it is a trochanteric fracture when you are suspecting or differentiating between the two. Apart from other findings, this is a very important finding that you should not forget to tell in the examination. So there can be circumstances where the patient may not be able to actively internally rotate in case of fractured neck of femur also, in which case it is possible. ICNF is there, but not able to actively internally rotate. So in which case it is possible?
Impacted neck of femur.
Not impacted. Impacted, there will not be no problem at all. Unable to get up already we told no. So he should be able to get up and go. We already told he is unable to get up. You are suspecting IC, but the point that he is not able to internally rotate, it is against your principle of making a diagnosis of IC. So what could be the possible if he is not able to internally rotate? So if there is a
basic cervical fracture.
Not basic. That comes to trochanteric fracture only. So what could have happened? Apart from fracture, what other structure could have been injured? How the patient with IC will rotate the limb internally? With which structures help?
Yes,
not iliopsoas. Better before that, inside the joint, or rather in the capsule. Iliopsoas is outside the capsule. A structure which is out along the inside the capsule.
Ligament.
What ligament?
Bijlani.
Yes, very good. So it's a ligament of Bijlani which acts as a fulcrum for rotation of the hip, even though there is a fracture of the neck of the femur in case of normal ICNFs. So if the fracture of the ligament ICNF also involves injury to the ligament of the Bijlani, or when there is a tear to the ligament of the Bijlani, though there is ICNF, patient will not be able to actively internally rotate. So this diagnostic point should not be forgotten. In case you are suspecting a fractured neck of femur, you have to correlate with the other findings to say that it is ICNF, not ECNF. So in case of ICNF, again, there is no fixed deformities. Corpus triangle tenderness will be there. Trochanteric elevation will be there. And the most important finding you must elicit in these cases is positive telescopy. If it is not there, don't commit a diagnosis of ICNF. It should be impacted only. We are talking about here unable to get up. That means it is not impacted. So positive telescopy should be there. So it's called as ununited intracapsular fractured neck of femur. So ununited intracapsular fractured neck of femur could be your diagnosis. So same if you go to the trochanteric fracture, it is an older age patient who has got a trivial trauma or sometimes severe trauma like in road traffic accidents in younger age group, but is definitely not able to walk. Definitely is not able to walk, and slowly, gradually it may become painless over the time. Over the time passes, both IC and EC may become painless because of non-union, one because of malunion. So it may become progressively painless, but there will be a major deformity that even the patient will appreciate. In those cases, if you examine, there will be a severe external rotation, and probably there is more tenderness over the trochanter rather than in this corpus triangle. There will be a definite irregularity or thickening of the trochanter with elevation, and the gross limb length discrepancy with severe external rotation. The diagnosis is trochanteric fracture, probably sometimes united. If you have so-called becoming painless and fixed, you may have a united fracture. If it is still painful, you can commit as a trochanteric fracture, maybe fresh or subacute. In case of history number 14, you take an adult who has presented you with significant trauma. So you suspect ICNF, ECNF, pelvis, all these things. After trauma, he will have delay to walk or difficulty to walk after trauma. So probably he may get up and walk maybe a few steps, but he will have definite problem in the walking. That indicates that there is a major trauma. You suspect something which is not visible to you. So you suspect something else. Your suspicion should go into the times of what we come next. Probably will become painful hip right now. So on examination, there will be a tenderness and no significant deformity. Trochanter is less prominent. That is, it appears as if it has gone inside. Your diagnosis should be what it could be. Less prominent trochanter, I told you already. Only one condition.
Central dislocation.
Yes, obviously you are suspecting a major trauma. Your trochanter is less prominent. You search for other things like mild shortening will be there, mild fixed abduction deformity, which is the only few conditions where you get mild fixed abduction deformities, and of course, concentric limitation of the movements and alters Morris test. Morris bitrochanteric test, the results will be unequal on both sides. It is called as central dislocation with hip arthritis. So these are all common diagnostic scenario that I have mentioned. By looking at a few things, you will be able to go to probable diagnosis. So you offer your provisional diagnosis. Before giving provisional diagnosis, always listen to the patient. Do not be so dogmatic about your findings and he may give important history like I have taken anti-tuberculosis treatment. Very clearly, he will say INH, everything I have taken, sir. District TB center, I have taken treatment. That will yearly give you your diagnosis. So try to listen to the patient. First, examine honestly, clues later, and with common sense only, examine the patient. Don't take clues from the seniors. As sir was telling, when I was appearing for the DNB exam, I failed in my DNB exam because there were great people who were examiners like Professor Lord, Professor S.S. Yadav, and then Thomas George. Those people that I had a very bad case in that to Thiruvananthapuram, Kerala. That lady was not telling me the history. I didn't know how to examine. It was a bilateral case, bilateral hip case. I was not really aware of all these possibilities. So one thing they told me, doctor, we know it is difficult to come to a diagnosis in this case, but we came here just to see how you approach a case. If you had approached properly, we would have passed you. That's what they told and left. Unfortunately, I failed. I didn't attempt again in that case. So anyhow, chart out your controversial clinical findings. Try to get explanations for them. You can narrow possibilities by your examination. Tell in order of priority your diagnosis. Don't jumble your diagnosis. Common things first, again and again, I'm telling. Correlate clinical picture. And in spite of all your best methods of examination, there is always a confusing case, as Sir said. Don't get confused. Be strong on your findings. If you can show them to the examiner will be very happy with you. And pass should not be a problem. Even good marks you can get by your power and your argument. So the diagnosis should always be etiological, pathological, anatomical diagnosis with the complications. As Sivananda sir was telling, you can add shown in a 41-year-old male, something like that. So it's a case of tuberculous arthritis, right hip with flexion adduction internal rotation deformity in a 41-year-old patient who is unable to squat or bear weight or presenting with instability. That you can tell. And finally, don't ever argue with the examiner. They judge how you approach a case rather than your capability to do a THR. So don't go on discussing how I do a THR and think of THR. You clear your examination first. Then if the questions are asked in THR, then you can answer them. Thank you very much for your all kind attention. And I hope I got you some knowledge which is of use for you in the examination. Thank you, sir. Thank you.
And sir, Raghunandan sir, you are given a full dish, sir. Only thing they have to eat it.
That's a really
everything served in a plate.
Sir, the only thing is, I request, it is not that easy as we have discussed today, sir. I understand.
Yes, sir.
As a postgraduate, I had also a lot of confusing diagnosis, signs and all these things. But what I mean to say is, you learn the ideal things first, try to elicit them. You would have always had a clue. So try to elicit them. You will always get it. You will always get it in ideal case because ideal cases are kept for you in the examination. If there are controversies, think about them. Use your knowledge, use your textbook knowledge to explain. And anyway, don't try to argue with the examiner. If he says this is wrong, you again go with him. Again, verify whether he is correct or not. He should always be correct, at least for the examination. So try to abide and try to go with them. Then you will be free of any trouble in the examination. Thank you, sir.
Last one, golden points.
And before passing my comments, another a little bit points to I want to add to the what Raghunandan sir has already discussed, already elaborated in depth. In the traumatic scenario, please remember, pain will be more initially, and then pain slowly subsides as the time goes on. That is the traumatic condition. Please remember. But in a disease condition, always pain starts insidiously and slowly progressive or non-progressive, again may progress to some extent. And there are certain diseases that the slow onset, pain goes up and then suddenly comes down and suddenly pain disappears. Okay, these are sometimes in ankles. So pain of traumatic origin, pain of non-traumatic origin, that's what you have to remember. So for every disease has a natural history. It borns, it grows, it dies. That is the address of that particular disease. That is what you have to identify always. Right? And in one more point I want to add that in tuberous arthritis, it is always need not have all the classical deformities of synovitis, classical deformities of arthritis of abduction, flexion, interrotation is not always will not happen. Because the patient which is bedridden only, you get all these typical deformities. The patient is not bedridden and the patient is ambulatory, you will not have this typical classical picture. Then one more thing is when there are no limb length discrepancies, there is no limb length discrepancy, there is no need for you to measure the Brand's triangle. Then another point I would like to add is, and there's a bilateral hip disease, there is no role for Brand's triangle because it is only comparative measurements. Then we have to depend on the Nelaton's line. Please remember these points. So there are certain arguments will be there. As Sir has said, always go with the examiner. You may be wrong or right, but go with the examiner. Never and never argue with the examiner. And really, Raghunandan, my heart is really glad today that I could arrange a wonderful lecture to all the postgraduates. And it was really, I see the books, Master Techniques in Some Surgery. I have seen books. But this is really a mastery talk from a senior most teacher. People are really, all the 61 postgrads joined today, including faculty, are really fortunate to listen to this talk. Thank you. I thank the OrthoTV also. Sorry, I could not inform them in advance due to some personal, somehow it went out of mind. So here afterwards, I will inform the OrthoTV also telecasted our program live, Raghunandan. Today.
Yes, sir. Thank you, sir.
But Shyam and Shamsud they're very kind enough to just log in time and then they recorded it. And all the PGs, they can watch it any number of times in future. As and when you have any doubt on the hip joint, you just log into this link and watch it again and again. So that you will become masters in the examination. You will not have any, whatsoever, you will not have any doubts. So in future, I would like to arrange two more talks, one on the radiology of the hip and another on the gait. So definitely that will complete the talks before you appear for examination. And once again, thank you, Raghunandan, for a really, I think you are really exhausted today. For a test stage, you have discussed 46 slides and it spanned, it is 1 hour and 45 minutes. I just counted the time also, one without a break. So really, we are thankful to you. Made this Sunday program really a very, very useful, a quality program. And thank you. And then anything to be added, Sivanand, because we will be concluding, because you are don't have time to discuss other things or discuss the other cases next time. You must pass your comments.
Sir, we are hearing about you, but today we learned so many things out of your talk and your experience. Exactly, last 14 slides is showing that your experience. So it is only possible with experienced persons and a good teacher. So woe you, sir, and we are welcoming again for our IOA PG teaching program. Please.
With Madam.
Please oblige with Madam, sir. Please oblige.
Thank you, sir. Yeah, correct.
Please oblige.
Sir, whatever we have learned through great teachers, only we have learned, sir, like Dr. Markandeya, Dr. Y. Krishna, Dr. Ramanrao, sir. They are all the teachers who infused some subject into us. We were totally new to orthopedics, sir, when we were postgraduates.
Yes.
We didn't know what is nail, what is plate. We were afraid to see even a case of osteomyelitis. So whatever is from them only, we could get what little subject we have. I owe entire my career to my teachers, sir.
Incidentally, Raman Rao sir also was my teacher.
Yes, sir. Raman Rao sir.
I think today is his ceremony. Today. We remember him also today.
Great moment, sir.
Great moment. And with these few words, Santosh, are you there, Santosh?
Yes, sir. Yes, sir.
Just propose vote of thanks and then we conclude the session.
Sir. Good afternoon, everyone. So, sir, Raghunandan, sir, like Udaykumar, sir, Sivanand, sir already said, it's really wonderful class. I learned a lot because I'm already away from this cold cases. So it was very useful for me. We sincerely thank you on behalf of North Andhra for taking your time out and presenting this class. Also, I thank Shivanand sir for being the additional faculty and Udaykumar sir for moderating the talk, and all the postgraduates too for active participation. Thank you, sir.
And wish all the exam going postgrads all the best. And thank you, Raghunandan.
Thank you, sir.
Please
Thank you, sir.
block your dates on June 18th and 19th.
Sure, sir.
And we request you to come with madam.
Thank you, sir. Thank you so much. Thanks for everyone.
Be our guest on the 2 days.
Thank you, sir.
Thank you so much, Raghunandan.
Thank you, sir.
With this few words, I am concluding the session. Once again, I thank OrthoTV and my best wishes to all the postgraduates. I am closing down, Raghunandan.
Thank you, sir. See you all, sir. Bye, sir.
Thank you.
Bye, sir.